Hello everyone, it's my pleasure today to address you today on this critical topic in pediatric nursing, the gastrointestinal disorders in children. As you know, that the digestive system plays a vital role in a child's growth, nutrition, and the overall health. But when it's affected by, let's say, a disease of any nature, the consequences of this can be severe. So, to understand these disorders that affect the gastrointestinal system, we must first of all explore the anatomy and physiology of the pediatric gastrointestinal system. So the pediatric tract is responsible for several processes, including digestion, absorption, and waste elimination. However, unlike adults, infants and young children have immature digestive system, which makes them more susceptible to malabsorption, reflux, and dehydration diseases. So, starting with the mouth and esophagus, you find that newborns generally they have a strong sucking reflex but have a poor swallowing coordination, and this normally increases the risk of aspiration. So normally we have the lower esophageal sphincter, also referred to as the cardiac sphincter. In this population, you find it's generally weak, and this normally leads to infrequent regurgitation or reflux of the food contents back to the mouth. Next, we have the stomach. So, in a newborn stomach, you find that the capacity is usually small, so it can hold between 30 to 90 meals. But as the baby grows, it expands with age. Here, you find that gastric production is low at birth but increases over time, and this one normally affects digestion. We also have slow gastric emptying, which normally predisposes the infants to bloating and reflux. Next, we have the small intestines. And the small intestines, as you know, is the main site for nutrient absorption. But in neonates, they have immature digestive enzymes, and this makes it hard to digest fats and carbohydrates. So we have increased intestinal permeability, which allows for passive transfer of maternal antibodies supporting the immune system. Next, we have the large intestines. Of course, the large intestines is responsible for water and electrolyte absorption. We have immature gut motility, which normally leads to variable stool patterns in infants, like we could have frequent stools in breastfed babies, constipation in formula-fed infants. Next, we have the liver and the pancreas. Liver in this kind of population is immature, so the liver is immature at birth, and this leads to reduced bile production and difficult metabolizing bilirubin, which can cause neonatal jaundice. I think this is one of the conditions that we are going to be looking at. The pancreas, on the other hand, has reduced enzyme activity, and this makes it difficult for the infants to digest fats. So for us to understand the different type of conditions, we have to know that we have different conditions affecting the GI. So we could have the GI disorders affecting the esophagus, like the gastroesophageal reflux disease, esophageal atresia, transesophageal fistula, and achalasia. We also have disorders affecting the stomach and the intestines, like the acute gastroenteritis. We also have peptic ulcer disease, hypertrophic pyloric stenosis, malabsorption syndromes like the celiac disease and the lactose intolerance, and they also have intestinal atresia. Disorders of the large intestines include conditions like constipation, the Hirschsprung disease, intussusception, necrotizing enterocolitis, and appendicitis. Disorders of the liver, the gallbladder, the pancreas could include conditions like the neonatal jaundice, biliary atresia, hepatitis, and pancreatitis. You also have congenital and structural anomalies like the Menkes diverticulum and the gastroschisis and omphalocele. So average we have around 17 conditions affecting the GI of the pediatric population. And to start us off, we'll start with the most common one, which is gastroenteritis. So this is a leading cause of diarrhea and dehydration in children, and it's often due to viral, bacterial, or parasitic infection. So, of course, the key concern is preventing dehydration through the ORT, and that is what we are supposed to be looking at. In mostly, it is viral, so it will be self limiting condition. So the small intestines will react to various causes of gastroenteritis with increased luminal fluid that can be absorbed. So abdominal pain, vomiting, severe diarrhea primarily, and secondary depletion of intracellular fluid will result. We also have dehydration and electrolyte loss occurring in these particular patients. The causes we have already mentioned, viruses, of which rotavirus and norovirus are the most common viral disorders. If it is bacterial, then you have to suspect a E. coli, the Escherichia coli, or Salmonella, the Shigella, or the Clostridium difficile. For parasites, you could have Giardia lamblia, which can lead to prolonged diarrhea, bloating, and malabsorption. Other conditions include contaminated food or water, and pasteurized milk products, and recent antibiotic use. Of course, poor hand hygiene, contact with pets and other animals, and contact with feces and vomiters from an infected person, consumption of contaminated water are some of the leading risk factors of this condition. Worldwide, gastroenteritis accounts for about 10% of pediatric deaths, and it is the second leading cause of death. Incidence of gastroenteritis has remained constant for the past 40 years. However, mortality rate has declined primarily because of the availability of oral rehydration solution in developing countries. In the United States, gastroenteritis accounts for about 1.5 million outpatient visits, 200,000 pediatric hospitalization, and 300 deaths annually. In US, we find that the norovirus has replaced the rotavirus as the leading cause of gastroenteritis in most pediatric cases. Complication of this condition could result into severe dehydration, electrolyte imbalance, and death. So, in terms of assessment, you could, in history, or try to elicit the acute onset of diarrhea, abdominal pain and discomfort, fever, nausea, among others. Physical examination, you could find out the abdominal distension, also the poor skin turgor with dehydration, increased heart rate, and hyperactive bowel sounds. In terms of diagnostic tests, you could do a gram stain and a culture of the stool or a blood culture, which will reveal the causative bacteria. Stool examination for ova and cysts may reveal a parasitic cause, while the rapid antigen testing of stool identifies the rotavirus infection. Stool analysis will reveal Clostridium difficile toxins, although it's rare in children younger than age 24 months. CBC will indicate increased white BCs, and this one will be able to help identify infection. A comprehensive metabolic panel identifies the electrolyte imbalances. In terms of treatment, you do the oral dehydration for mild to moderate dehydration. Initially, start with clear fluids as tolerated if vomiting is present. You do regular diet as tolerated if diarrhea is present, and electrolyte replacement solutions such as the Pead diet. You need to avoid dietary products, and you need to put these patients in a private room if the only available options are uh, cases that could result into cross infection, right? So you use ondansetron hydrochloride for vomiting once the cause has been identified. Ondansetron hydrochloride is a selective serotonin receptor antagonist, and serotonin is a neurotransmitter that normally causes nausea when present in the stomach. Nursing intervention, you need to administer prescribed medication and monitor side effects. You cluster nursing activities to minimize energy expenditure and provide frequent uninterrupted rest periods. You encourage the use of energy conservation measures and initiate standards and conduct precautions as appropriate. Provide meticulous periannual care to prevent diaper rash if applicable. And if the skin breakdown occurs, you need to monitor or report it to the physician and leave the diaper area open to air. You also need to inspect the skin and the mucous membrane for signs of dehydration, maintain IV access and administer IV fluid as ordered. You have to encourage fluids as tolerated. You maintain a child with diarrhea on regular diet if possible. Monitor the child's input and output. Assess stool pattern for amount and characteristics. Check stool for occult or flank blood. You consult with a child a life specialist to provide age-appropriate instructions and support, and collaborate with social services to provide counseling, community services, and support. Ladies and gents, that's all about gastroenteritis. The next condition is the dehydration and diarrhea. Of course, the two are complications of the first one, the gastroenteritis. And dehydration in children is commonly caused by gastroenteritis, which you have already looked at. We also have other causes like fever, excessive sweating, inadequate fluid intake. So, in terms of history taking, diarrhea, vomiting, sweating, fever, and polyuria, they normally lead to fluid loss. We look at the intake history where the caregiver might report that there is reduced oral intake, there is difficult feeding. Also, the number of vomiting and duration episodes and urine output has to be recorded. Also, try to elucidate symptoms such as lethargy, irritability, sunken eyes, dry mouth. We also have underlying conditions like chronic illness, diabetes, and kidney diseases. We could do physical examination where you find the child will be alert, irritable, lethargic, and unconscious. We'll also do the pinch test where we're going to have slow recoil in dehydration, sunken eyes, dry lips, and tongue. We could also have sunken fontanelles in severe dehydration for the infants. We could also have prolonged capillary refill that is greater than 2 seconds, and that could suggest hypovolemia. We'll also have tachycardia, hypotension in severe cases, deep and rapid metabolic acidosis, oliguria or anuria in severe dehydration. For the lab tests, we could also have a sodium potassium bicarbonate levels affected. Also need to assess for renal function. You rule out hypoglycemia or diabetic acidosis and check for metabolic acidosis. So we normally classify this condition dehydration. So we could have the most severe form of dehydration where the child could present with hypovolemic shock from diarrhea or dehydration. So you could classify the child as so if the child presents with a weak or absent pulse, they have altered level of consciousness, so they are not alert. They could be presenting with cold hands, the cold hands and increased capillary refill, plus either sunken eyes or very slow skin pinch. So for such a patient, you need to treat for shock. So you give them brinker's lactate 20 mils per kg. Then a second bolus may be given if required before proceeding to step 2 of Plan C. Otherwise, you also need to treat for and prevent low blood sugar. You assess for severe acute malnutrition. Also assess for severe anemia. If the HB is less than 5 grams per deciliter, you have to transfuse. Remember, we normally transfuse for adult if it is less than or equal to 7, right? Also, you need to admit and refer urgently to a hospital and screen for other diseases common some suspects like the TB and the HIV. Remember, you'll also classify the child as severe dehydration if they have either of the two signs that have been stated here. They are either lethargic or they have impaired or low self consciousness, sunken eyes, not able to drink or drinking poorly, skin pinch goes back very slowly. Such patients, you give them or you treat them using the plan C of managing dehydration. Give them vitamin A, give ORS and zinc sulfate for that case. Remember, you can also classify them as maybe some diarrhea, some dehydration, or no dehydration. So for dehydration, according to MCI, we could have hypovolemic shock, which is the most severe form, then go to severe dehydration, some dehydration, and no dehydration. In terms of diarrhea, we could have either severe persistent diarrhea, where diarrhea is present, and we could also have hypovolemic shock or severe dehydration or some dehydration. And in that case, you treat hypovolemic shock and any other form of dehydration before referral, unless the child is having other signs. You give vitamin A, ORS, zinc sulfate, multivit, and mineral supplements. From severe persistent diarrhea, you could also have the persistent diarrhea. And lastly, you could have dysentery, where the patient is going to present with blood in stool. Such patients you treat using ciprofloxacin. Ciprofloxacin, remember, it's a fluoroquinolone drug, antibiotic. You also give vitamin A, give ORS and zinc sulfate, and do follow-up in 2 days. You screen also for TB disease and check for HIV disease. Ladies and gents, we had already talked about dehydration. We could have severe dehydration, some dehydration, or no dehydration, right? No dehydration in children. So generally, prevention of dehydration in children, you need to encourage adequate hydration, especially in hot weather when the child is presenting with fever or has diarrhea. You do early oral rehydration therapy at the first sign of dehydration and or vomiting, and then educate caregivers on the signs of dehydration and when to seek help. You also need to ensure that the child has received the necessary vaccination, like the rotavirus, to prevent severe dehydration. All of us know that the rota is safe and effective vaccine that protects children from rotavirus infections. Rotavirus is the main cause of diarrhea in developing nations. That is, you need to know. So the vaccine is given as drops in the child's mouth. The number of drops depends on the brand of the vaccine. The first dose should be given before 15 weeks, and the last dose should be given by 8 months of age. Ladies and gents, we also have malnutritions that normally go hand in hand with dehydration, and these are other associated conditions. So remember, malnutrition can present as undernutrition or overnutrition. Of course, malnutrition is a condition that results from imbalance between body's nutritional needs and the intake or the utilization of nutrients. So, for the case of undernutrition, this could result from deficiency of essential vitamins or nutrients, leading to conditions such as standing, wasting, underweight, and macronutrient deficiencies, e.g., anemia due to iron deficiency anemia. As for the case of overnutrition, we could have a case of excessive intake of nutrients, leading to conditions such as obesity, hypertension, and diet-related non-communicable diseases, e.g. diabetes, cardiovascular diseases. Malnutrition can affect individuals of all ages, but it is particularly critical in vulnerable populations like the infants, children who belong to the pediatric population, which is the topic of interest today. So according to AMCI, Integrated Management of Neonatal and Childhood Illnesses approach, if a child is presenting or you're suspecting malnutrition, you need to ask if there is any history of TB contact. So you need to look and listen, because TB is one of the major conditions that results into malnutrition. In fact, in many quarters, it's referred to as the wasting disease. You also need to look for edema of both feet and determine the child's weight for height or length, and plot it on the IMCI chart booklet to determine the Z score. Determine the growth pattern. Is the growth pattern flat, faltering? Weight curve is or dropping for at least 2 consecutive months. You need to measure mean upper arm circumference in millimeters in children who are 6 months or older. If the weight for height or length is less than 3 Z score, or the mark is less than 115, then you have to suspect that there could be malnutrition. So malnutrition can also be classified according to MCI into different categories. We have severe acute malnutrition with complication for children. We also have the severe malnutrition without complication. We also have the moderate acute malnutrition, and those baby at risk of acute malnutrition. Lastly, we have no acute malnutrition classification. Malnutrition also go hand in hand with anemia, so you need to also to classify that. Remember, for severe anemia, we have severe pallor with HB less than 5 grams per deciliter. Such children you need to treat to prevent low blood sugar. You keep the child warm and admit them or refer urgently to a hospital. You screen for these common diseases that are normally suspect in such a case, like the TB disease and the HIV disease. Lastly, they can also classify of anemia. So when the child presents with some palmapella, or just no palmapella where there is no anemia. In such a child, if the child is less than 2 years old, you just need to assess the child's feeding and counsel the mother according to the feeding recommendation. If feeding problems, you need to do follow-up in 5 days. You give albendazole if a child is 1 year or older, and has not had a dose in the last 6 months. You immunize the child according to the schedule, and then you screen for our 2 major suspects. Remember, for malnutrition, we have 3 major formulas that you need to be aware of. We have the F75, we have the F100, and we have the root 2. Right? So the F71 and 75 and 100 are therapeutic meal formulas used in the management of SAM, which is severe acute malnutrition in children, and it's designed to provide the necessary nutrients for recovery in different phases of treatment. Let's say, like for F75, this one is normally used in stabilization phase, and is used initially for children with some who are critically ill and have complications such as infection, dehydration, hypoglycemia. It does provide a low protein diet of about 0.9 grams per 100 mils, low sodium, and 75 per 100 ml to allow for gradual metabolic adaptation and avoid refeeding syndrome. So it's given for 2 to 7 days until the child stabilizes and can be transitioned to the F100. So F100 is also referred to, or used in the rehabilitation phase, and this is used after stabilization has happened. So it is F100 is used to promote rapid weight gain and recovery. It provides higher energy, that is 100 kilocalories per 100 meals, and protein of about 2.9 grams per 100 meal, and this is just to support catch-up growth. Is normally given until the child reaches a health weight for height, or transition to a home diet. So the home diet, in this case, it will be the root of, right? The root of for community support. Well, so after looking at this first 2 and coming up with some of the complications associated with it, we can now move on to the third condition, which is gastroesophageal reflux disease. And this one is characterized by backflow or reflux of gastric acid that results into acute epigastric pain, usually after a meal. passage of gastric contents into the esophagus is what is called as gastroesophageal reflux, and it's a normal physiological process. Gastroesophageal reflux disease, now it is associated with it refers to the gastroesophageal reflux and its associated symptoms or complications. It's popularly known as the heartburn. So it's an umbrella term for spectrum of manifestation classified into categories based on symptoms and endoscopic findings, underlying pathophysiology, and reflux monitoring. It has four subgroups. We have erosive reflux disease, reflux hypersensitivity, non-erosive esophageal reflux disease, functional heartburn, and functional heartburn is the most prevalent form of gastroesophageal reflux. It's the most common reason for gastroenterology referral for infants. So we have the gastroesophageal reflux, which occurs when lower esophageal sphincter is deficient or when pressure in the stomach exceeds the lower esophageal reflux pressure. So this makes the lower esophageal reflux to relax, and acidic gastric contents will regurgitate into the esophagus. Gastroesophageal reflux occurs naturally in more than 25% of infants and peaks at about 3 to 4 months and commonly self-resolves in the time. The degree of mucosal injury is based on the amount and concentration of reflux gastric acid, proteolytic enzymes, and bile acid. Gastroesophageal reflux disease occurs when reflux triggers esophageal and extraesophageal symptoms, causing the child to stop eating and resulting into weight loss. So we could have any condition that increases intra-abdominal pressure, like let's talk of gastroparesis, pyloric stenosis, and gastric outlet, hiatal hernia, pyloric surgery. All these can predispose to this condition. In terms of incidence, gastroesophageal is a common physiological phenomenon in more than 25% and peaks around age 3 to 4 months. Symptoms usually decrease by age 6 months due to the addition of solid foods to the diet and spending more time in the upright posture. So 90% of infants have complete resolution of symptoms by age 10 months. Gastroesophageal reflux disease affects all ethnic groups and all socioeconomic classes. Gastroesophageal is more common among children with a history of prematurity, pulmonary disease, and developmental delay, or the neuromuscular disease. So complication associated with gastroesophageal reflux includes inflammation of the esophageal lining due to chronic exposure, causing pain and discomfort. We also have scarring from repeated irritation, leading to narrowing, causing swallowing difficulties. We also have chronic acid damage resulting in open sores, leading to pain and potential bleeding. We also have Barrett's esophagus, which is a rare condition in children where esophageal cells undergo metaplasia, increasing the risk of cancer. Anemia, reflux aspiration, bronchoconstriction, dental abnormalities, and weight gain are some of the other complications. In terms of assessment, we have common signs of gastroesophageal reflux like frequent vomiting, inability, irritability during feeding, refusal to eat, wet palms, and colic behavior. Physical findings, we have the pharyngitis, crying, irritable, dysphagia, whatever, and these other conditions. In terms of test, we could do the hemoglobin level, which may be reduced if esophageal erosion is leading to bleeding. In terms of imaging, an esophageal pH, which is the gold standard test, we could do that. So that the upper GI radiography study may also be used to evaluate anatomy, although it is not used to diagnose gastroesophageal reflux disease. Gastric emptying study demonstrate reflux or delayed emptying. A gastric skin scan can diagnose gastric emptying and gastroesophageal reflux, but is used mainly to detect aspiration. Esophagography helps to evaluate integrity of esophageal peristalsis. Treatment of gastroesophageal reflux. We need to identify the specific GFI phenotype, which helps select the most effective treatment. Nutritional management, the mainstay of infants younger than one year. We also need to do lifestyle modification, thickening of formula or human milk, positional therapy, removal of the cause, elevation of the head of the bed or the crib, avoidance of supine position immediately after meals. You encourage upright posture after feeding for the infant and frequent bumping with the feeding. You also need to encourage weight reduction if the child is obese. So they need to avoid foods that can worsen symptoms, avoiding of 2 hours before sleeping, small frequent meals, so you avoid overfeeding. You could also encourage the parental nutrition or the transpyloric jejunal tube feedings for gastroesophageal reflux that is refractory to optimal treatment. Also, addition of thickening agent to a formula, a minimum of 2 to 4 week trial with extensively hydrolyzed protein or amino acid based formula. Only for this intractable GERD. Breastfeeding or human milk feeding, that is maternal avoidance of the cow milk, is also another cause. So we have some foods that can increase lower esophageal pressure like proteins, carbohydrates, non-fat milk, low dose. While factors that can decrease lower esophageal pressure include fats, whole milk, oranges, tomatoes, anti-flatulent, chocolate, high dose ethanol, lying on the right side, left side, cigarette smoking. Gastroesophageal reflux disease occurs when stomach acid frequently flows back into the esophagus, causing irritation. It is common in infants due to the immature lower esophageal sphincter that we had talked about in the introductory section. In terms of medication, we can use antacids such as aluminum hydroxide, magnesium hydroxide, and calcium carbonate. We could also do the histamine 2 receptor antagonists such as cimetidine hydrochloride, famotidine, nazitidine, proton pump inhibitors such as lansoprazole, pantoprazole sodium, rabeprazole sodium, esomeprazole magnesium for esophageal healing. We also need to use the prokinetics such as the baclofen prior to surgery when other treatments have failed. We also need to have the surface and agents such as the sulfate, and we also have the simethicone to decrease gas pressure and IV fluids for hydration. Special consideration are necessary when treating pediatric patients with gas, so you keep this point in mind. Infants are treated with proton pump inhibitor either alone or in combination with the H2 receptor antagonist. And these ones, they will be at greatest risk for fractures during childhood. So you also need to be aware of that. Mucosal pro, uh, protectants, such as the algigates, aren't recommended for the treatment of GFI in infants and children due to limited evidence of their effectiveness in this age group and also possible presence of aluminum and calcium salts in these products. The use of probiotics and herbal medication is not recommended in this group. So the other condition is achalasia. So achalasia is a rare esophageal motility disorder that is characterized by failure of the lower esophageal sphincter to relax properly. Remember, for the GFR, it was relaxing and allowing contents from the stomach to get into the esophagus. But for achalasia, the lower esophageal sphincter is failing to relax properly. So this leads to impaired passage of food into the stomach. This results into progressive difficulty in swallowing, regurgitation of undigested food, and other complications. So it's more common in infants between in individuals of ages between 25 to 60, and some familial cases have been reported. So achalasia is generally caused by this trypanosoma cruzi, right? Trypanosoma cruzi, where there is production of autoantibodies that results into inflammation and ganglionic cell loss and fibrosis, resulting into Achalasia. So the failure of cardiac sphincter relaxation prevents normal food passages, causing progressive esophageal dilatation and food stasis. And over time, esophageal muscle fibrosis and loss of peristalsis worsen this dysphagia and regurgitation. So we have progressive dysphagia, difficulty in swallowing, regurgitation, and chest pain as the main symptoms of achalasia. The gold standard in terms of diagnosis we normally do esophageal manometry, which will show us the absence of peristalsis and failure of the cardiac sphincter to relax. Barium swallow can also show the bird's bleak appearance, while EGD, esophagogastroduodenoscopy, will help us rule out malignancy or secondary causes. In terms of treatment, we could do the calcium channel blockers like nifedipine, which is normally used to relax the lower esophageal sphincter. Also use the nitrates like the isobide dinitrate, which will help reduce sphincter pressure. And lastly, we have the botulinum toxin. Botulinum toxin normally blocks acetylcholine release, and this one is injected directly into the lower esophageal sphincter during endoscopy. So this will help paralyze sphincter muscle, and it will inhibit acetylcholine release at the neuromuscular junction, relaxing the lower esophageal sphincter. We could do pneumatic balloon dilation, which forcefully stretches the lower esophageal sphincter. In terms of nursing intervention, you educate the patient on dietary modification, you do ensure aspiration precautions, and you monitor nutritional status and hydration. The fifth condition is the Hirschsprung disease, and this disease is characterized by absence or marked reduction of parasympathetic ganglion cells in the colorectal wall. This condition is also referred to as congenital megacolony, congenital aglionic megacolony, colonic angioliosis, and Hirschsprung associated enterocolitis, intestinal angioliosis, and angiolionic megacolony. So it mostly affects the rectosigmoid region in the GI, and you have to know that this disease follows familial pattern in approximately 10 cases. It's sometimes associated with genetic mutation, at least eight genetic mutations. So we have the RET proto-oncogene is the one responsible for about 50 cases of familial cases and 20% for the sporadic cases. So, Hirschsprung disease can result into complications like the bowel perforation, electrolyte imbalance, nutritional deficiencies, enterocolitis, hypovolemic shock, and the sepsis. So, after surgery for Hirschsprung disease, complication can also occur. We could also have astomotic leak, wound infection, adhesions, or incontinence. In terms of assessing, remember, patients are going to present with history of failure to pass meconium within 48 hours. So Hirschsprung disease, remember, it's also referred to as congenital aganglionic megacolony. Congenital means it will be present at birth, and aganglionic is the cluster, ganglion is cluster of nerves. So megacolony is blocked colony, right? So we have the Hirschsprung disease presenting with those major signs and symptoms. So we could do barium swallow, which will reveal narrowed segment of the distal colon. We also do upright plain abdominal radiography, which will show marked colon distension, intestinal blockage, and an early rectum, right? Remember, a rectal biopsy is the gold standard for confirming the diagnosis by showing the absence of ganglion cells. You could give them broad spectrum antibiotics or senna extract for constipation, cholestyramine or loperamide hydrochloride for diarrhea, on a bullitoxin begin postoperatively to reduce normal bowel movement patterns, IV fluids for hydration. You could also perform the surgery for removal of a ganglionic portion of the bowel, repair of the mild cases during infancy. That is just one surgery. So patients with Hirschsprung disease, nurses will need to administer prescribed medications and monitor their side effects. You need to administer fluids as ordered and maintain patent IV access. You monitor fluid and electrolyte imbalance, provide adequate nutrition orally and parenterally based on the infant's condition, and maintain nasogastric tubing on the suction for decompression as ordered, provide nasogastric tube care. Give saline enemas as ordered to decompress the bowel, and also provide meticulous perianal care. If the infant has diarrhea, you need to leave the diaper area open if excoriation is present. Position the infant upright to relieve abdominal pressure so that they can lead to respiratory distress. Prepare the infant and family for surgery. Measure the infant's abdominal circumference. Encourage the parents to verbalize questions, concerns, feelings, so that as you actively listen and answer those questions honestly. You also need to encourage the parents to participate in the infant's care and point out positive aspects of the infant to promote bonding. If an ostomy is planned, you elicit the aid of a wound. Ostomy, continence nurse has to assist with the preparation for the surgery and postoperative care. Consult with the child's life specialist to provide age-related instruction and collaborate with the health services to provide counseling and community services. So the other conditions about esophageal atresias and transesophageal fistulas. So this is two in one conditions. And esophageal atresia is a rare birth defect whereby the baby's esophagus is presenting with several challenges. So in most cases, you find the upper part of the esophagus will not be able to connect to the lower part of the esophagus. And it usually ends in a pouch, which means that the food cannot reach the stomach. It often happens along with another if birth defect. So, and that is tracheoesophageal fistula, abnormal connection between the esophagus and the trachea. So the connection part is the one that this one can develop into life-threatening problems such as choking and pneumonia if not treated quickly. So we have during growth where we have esophagus and trachea normally growing together, and then what results in this condition is when they fail to separate, so they form this fail to separate, and there's abnormal connection between the two. So we have different types of esophageal atresias. Number one, have type A, type B, type C, type D, and type E. So type C is the most common type. In type A, we have isolated esophageal atresia. So the upper and lower segments of the esophagus end in pouches like dead-end streets that don't connect, and the middle part of the esophagus will be missing. In this type A, there is no transesophageal fistula. In type B, Transesophageal fistula will be present in the upper segment. So, and this condition normally increases the risk for aspiration pneumonia. Type C, transesophageal fistula will be present in the lower segment. Remember, the type B was in the upper segment. And in the lower segment, we are saying that this is the most common type of tracheoesophageal fistula. Right? The most common transesophageal fistula is type C. Type D fistula is present on both upper and lower part. And type E is where we have it is a H type. So the transesophageal fistula is there, but the trachea and the esophagus are connected normally, right? They are connected. They're typically normally connected as that case, right? So the type E, tracheoesophageal fistula. So here we don't have esophageal atresia. The esophagus is there. The upper part of the esophagus and the lower esophagus and the mid lobe joined together. So we could do prenatal suspicion based on ultrasound findings such as Potch sign and distended fetal hypopharynx, and postnatal assessment if symptoms arise. Antibiotics, ventilator, chest tube, those are some of the medications that you need to be on. Constipation is characterized by infrequent, hard, and painful stool. Intersusception is a medical emergency where one segment of the intestines telescopes into another one, causing obstruction and ischemia. So in such a case, you find there is intermittent severe abdominal pain, red currant jelly stools, vomiting, palpable sausage-shaped mass. Necrotizing enterocolitis is a serious condition affecting premature neonates, characterized by intestinal inflammation and necrosis. Celiac disease, on the other hand, is an autoimmune disorder that is triggered by gluten ingestion, leading to small intestinal damage. So patient will present with chronic diarrhea, failure to thrive, and abdominal pain, bloating, and anemia. Management, we have lifelong gluten-free diet and nutritional supplementation. The foods that you're supposed to avoid for celiac disease are the rye, barley, wheat, and triticale. So remember, you have to assess for symptoms for celiac disease, obtain health history, promote gluten-free diet, educate the family on the importance of avoiding gluten-containing foods. Wheat, barley, rye have to be prevented so that you are not to avoid this intestinal damage and try and alleviate the symptoms. The other condition is Meckel diverticulum. Meckel diverticulum is a congenital remnant of the omphalomesenteric ducts, which causes bleeding or obstruction. So the patient presents with painless rectal bleeding, intestinal obstruction, volvulus, and diverticulosis. You need to manage it by surgical resection in symptomatic cases. So Meckel's diverticulum. We have a pouch on the small intestine that is present at birth. You're able to see that, right? And that is what is going to be causing the challenge. Omphalocele and gastritis. So gastritis, which is represented here on the far right, is a defect in the abdominal wall, usually in the right of the umbilicus, with exposed intestines not covered by the membrane. Omphalocele, on the other hand, which is on the immediate right, this one is a midline defect at the umbilical ring where abdominal contents herniate into a sac formed by peritoneum and amniotic membrane. And you can be able to see some of these differences between these two conditions. The next condition is appendicitis, and appendicitis is inflammation of the appendix, often due to obstruction. It is the most common pediatric surgical emergency. Patient presents with periumbilical pain shifting to the right lower quadrant, the McBurney's point, nausea, vomiting, fever, rebound tenderness. Management, we normally perform the appendectomy, that is surgical removal of that. Also along with IV antibiotics if preparation is indicated. The other condition is lactose intolerance. Remember this one, we covered it under metabolic disorders. And this results from deficiency of lactase enzyme, leading to the inability to digest lactose. So the patient presents with abdominal pain, bloating, diarrhea after lactose ingestion. So in terms of management, you need to advocate for lactose-free diet, or you can also give the lactase enzyme supplements. The next condition is the neonatal jaundice, and this is a condition in the newborns characterized by a yellow discoloration of the skin and the sclera due to the elevated bilirubin. It results from accumulation of unconjugated or conjugated bilirubin in the bloodstream. So it can be caused by physiological or pathological factors. Physiological jaundice is the most common and it is self-limiting. It occurs after 24 hours after and peaks at about 3 to 5 days. So we can classify jaundice as severe jaundice, or no jaundice. In terms of tests, we could do serum bilirubin levels, transcutaneous bilirubinometry, and the Combs test. Remember Combs test, it is used to distinguish between hemolytic or non-hemolytic jaundice, CBC and LFTs along with that. The other common condition is poisoning, and poisoning is the most common cause of poisoning in children is the use of the over-the-counter medication, and it results from several causes. Remember, poison is an agent of injury to humans, usually by chemical reaction, when a sufficient quantity is absorbed through the epithelial lining of the skin or the gut. When you have such a cases, you normally use the Dr. ABC so that you work on the airway, neurological, pupil, vital signs, skin, and odor in that particular order. In terms of diagnosis, you could do blood tests, ABGs, ECG, radiographic imaging, and urinalysis. So you start with immediate resuscitation, ABC, then decontamination, antidote administration, supportive care, and prevention and education. Lastly, you have pyloric stenosis. Pyloric stenosis is a condition in which pyloric muscle, that is between the stomach and the small intestines, becomes hypertrophied, leading to gastric outlet obstruction. This condition primarily affects infants between ages 2 to 8 weeks of age, and is more common in males than infants. The biggest reason why it's more common in males is because men have higher levels of testosterone, which can influence muscle hypertrophy, leading to pyloric muscle. Some studies also suggest delayed gastric emptying in males compared to females. So you could do abdominal ultrasound to confirm diagnosis, or barium swallow and blood test. So in terms of the nursing disorders for gastro, we could talk of fluid volume deficit related to diarrhea, vomiting or poor intake, imbalanced nutrition less than body requirements related to malabsorption, nausea or feeding difficulties, risk for electrolyte imbalance related to persistent vomiting, diarrhea or fluid loss, acute pain related to abdominal cramping, inflammation or obstruction as evidenced by crying, inability, irritability, or that behavior. Also, risk for infective tissue perfusion, in risk for impaired skin integrity, delayed growth and development, infective airway clearance, and parental anxiety related to child's illnesses. So those are some of the major disorders of the respiratory of the gastrointestinal system. So pediatric disorders generally require careful assessment, prompt intervention, and compassionate care. So, as nurses, we must use our knowledge, skills, and empathy to ensure the best outcome for our young patient. We have to continue to embrace our responsibility as nurses, caregivers, educators, and advocates, ensuring that every child receives quality, holistic care. Thank you, and let's continue learning and making the difference in the pediatric nursing.